inactive. And then you have the what? External urinary orifice. Then you have the external urinary orifice. Now the renal portion of the renal system of the body performs many vital functions. What are the functions? Primarily it is responsible for pH regulation. It is responsible for water regulation. It is responsible for electrolyte regulation. It is responsible for excretion of endogenous excretory substances. It is responsible for excretion of exogenous substances, drugs metabolism, and there is a very important part in endocrinology or hormones. Now, what are the three most important hormones that we need? What are the two most important hormones that is being worked up in the kidney? The first is kidneys. My God, that is enough. That is adrenal gland. We are talking about kidneys. Exactly, vitamin D. And the second thing, first is vitamin D. The second thing, erythropoietin. And the third most important thing, renin. Renin. The third most important thing, renin. And you can say aldosterone system. And what's stimulating kidney? These will give me those downloads that you are a student of classic. Okay, I hate that word. Also, it is. I don't delay PG anymore. Okay. So the renin and aldosterone system is present at it is that which nephrons? Exactly, juxtamedullary nephrons. Now, what do you mean by juxtamedullary nephrons? Yeah, they have a long heavily. Okay, they have a long heavily. So, right? There are two patterns. One is the basic theory, and then there is the complete renal consciousness. Okay, so there are two parts. Primarily, it comprises of urea and creatine. Primarily, it comprises of urea and creatine. So whenever you get hold of urea and creatine, you should be very knowledgeable about how the metabolic pathway functions. Okay, you should be very knowledgeable about how the metabolic pathway functions. Now let us start with creatine. Okay, creatine is basically a reservoir from air, from muscles. Okay, and it is obtained from creatine. It is obtained from creatine. What is creatine? Creatine is a high energy compound. It is a high energy compound which liberates loads of energy, enabling your muscles to contract easily and release energy requirements. Okay? That is creatine. Now, this creatine will, after spontaneous hydrolysis, becomes creatine phosphate. What do you mean by spontaneous hydrolysis? A water molecule comes out of its core. There is no enzyme working for it. It is a non-enzymatic pathway that the water molecule is expelled and the creatine becomes creatine phosphate. And then this phosphate group is removed. That is dephosphorylation. And it is dephosphorylated to form creatinine, which is an excretory product. Okay? The phosphate group is then dephosphorylated to form creatinine, which is an excretory product. Now, what are the typical features of creatinine? What are the typical features of creatinine? The first and foremost most important role of creatinine is it is mostly fixed. The amount of creatinine is mostly fixed. The amount of creatinine that is present in your body is mostly fixed, and the amount of creatinine that is supposed to be excreted in urine through normal physiology is also fixed. Why? Because it depends upon your body mass, body muscle mass, and it is not easy to change your body mass. It is not easy to change your body muscle mass. In order to do that, you either need to go to an intense exercise level, or you need to undergo a severe state of food deprivation in order to change your body muscle mass. Yet, how is it not help to us? There is a sudden increase of your creatinine levels in blood. What does it say to you? Something is wrong. This fixity of creatinine allows us to use creatinine as a parameter in order to analyze what is your GFR. That is your glomerular filtration rate, thereby giving you an idea of the entire kidney function. Thereby giving you an idea of the entire kidney function. Okay? Suppose you are dragged all around the college. It is there for a day. Next day, your blood creatinine levels are estimated. Will you find any change? No, you will not find any change. It is fixed. And in accordance to muscle mass, it varies. There is a very mild variation that is in accordance to your body weight, your gender, and your age. That is why we are using creatinine to make an estimate of the kidney function. This will give you an idea about the condition of the kidney. Now, the condition of the kidney can be changed under two circumstances. It can be changed under two circumstances. The first circumstance being the presence of unborn kidney or non-renal system disease. Suppose a person is suffering from liver. A person suffers from pulmonary embolism. A person suffering from a severe. Will you find normal kidney function in that patient? Yes or no? Will you find a normal kidney function in that patient? Yes or no? Yes? No. Very well. Fine. Because whenever the body is at an onslaught, our internal homeostasis has a tendency to provide extra blood supply in the affected organ to keep it functioning. Okay? So suppose you have had a heart attack or a myocardial infarction, the natural tendency of the body is to shift more fluids to the heart so that it can be well perfused. Okay? Who supplies the kidneys. It is taking up basically the blood supply of the kidney. Any insult of the body, any injury of the body, the blood supply of the kidneys will be cut off and it will be directed and connected to the alternate nervous system. But the good thing for us is kidneys are a very resistant organ. Kidneys are a very resistant organ. So they can function properly even after 48 to 72 hours after its blood supply has been redirected to somewhere else in order to protect the organ. Okay? In order to protect the organ, the kidney can function well up to 48 to 72 hours. After that, due to lower renal function of the kidneys, with time, slowly the renal function deteriorates due to ischemia of your nephrons. Due to ischemia of your nephrons. And when the patient has in that condition, we call it ATL or ARF. Acute renal failure or acute tubular necrosis. Acute renal failure or acute tubular necrosis. The organ being at this stage, the injury to the kidneys can be stopped and reverted. It is not a fixed condition. The damage is not permanent. The damage is not permanent. So if the patient adequate therapy, the kidney function will improve. It is a transient state. It is a transient state. Okay? But if this condition is not reversed, then the patient will acquire permanent kidney damage. There will be death of neurons, the nephrons. There will be death of nephrons. The amount of nephrons that is present in the renal system is about 1 to 1.3 billion. 1 to 1.3 billion. So as these nephrons are killed or die, your ability to secrete urine and your renal function goes down. That is what happens when you have a exogenous disorder. Exogenous, I mean non-renal disease. So suppose you have a very high fever versus 2000. Now can you tell me why the urine is important? You are trying to why that is important for the patient? Because you never know that an active metabolic state has caused any injury and whether you need to reverse it. That is why if your renal function test is given along with liver function test as a screening tool for all patients having a disease process. Because when the symptoms will be there, when the urine will decrease, or when the person will swell up due to exhalation of excess water into the body, due to the decline of the renal function, by that time it is too late. Because the acute tubular necrosis or the acute renal failure part can only be reverted within 48 to 72 hours. After that, it becomes permanent damage. After that, it becomes permanent damage. So the funny thing about creatinine is, it is neither secreted in the tubules nor it is there. So the amount of creatinine that is flowing into your kidneys is more or less constant. The amount of creatinine that is flowing into your bloodstream and is flowing into your kidneys is more or less constant. So with the ratio of these two, it is almost fixed, and that is called creatinine clearance. The ratio of the creatinine that is being excreted in one circulation is fixed, and that is called the creatinine clearance. And we are using this creatinine clearance in order to estimate our glomerular function. And how do we do that? We do that with the help of the wall model. And what does it say? H minus 170 straight into 170 minus H by 88 K multiplied by 170 minus H divided by 88 concentration. This will give you an approximation of EMR or E units. It will give you an approximation of EMR or E units. So the EMR is inversely proportional to the creatinine concentration. That is, if the creatinine concentration increases, that means there is stimulating function. And with this formula, we have been able to classify renal disorders into 5 classes. Stage 1, Stage 2, Stage 3, A and B, Stage 4, and finally Stage 5. Okay? So the Stage 1 is greater than 90% of the premade function. Stage 2 is 60 to 90%. Stage 3A is 45 to 60. Stage 3 is 30 to 45. Stage 4 is 15 to 30. And finally, stage 5 is less than 15. And this is called ESRD or end stage renal disease. When a person is in the class 5, that is in ESRD, then the person does not have the capacity to form urine anymore. That person is dependent upon hemodialysis to take care. The person is dependent upon hemodialysis or influx. Exactly, good. What is the renal? This is will be asked in your first year. It will be asked in your second year. It will be asked in your final year. And if you are a serious thinker, it will stick with you your entire life. Remember 80, remember 50, remember 5 stages, and keep on subtracting 50. That is how you do it. That is how you do it. It's so easy. Okay? So that was about creatinine. Now let's talk about the second most important analyte, and that is what? Urea. You like the urea? You like the urea? Don't like the urea? Okay, very good. Don't like the urea? You want the urea to make your body further? Okay. Will you start smelling like the washroom? Okay. So what is the funny thing about urea? Why do you need urea? Tell me. But why do you need urea? Is there somebody else? Why nature made urea? Where is it coming from? Double that. I have repeated this so many times. Where is urea coming from? Urea is a waste product of what? Brain tissue. If your brain tissue die, will it give you urea? Yes or no? Wait. What? If your brain tissue dies, will it give you urea? No. Very good. It will. Because our body is made up of proteins. And these proteins have a warranty period. If it is within warranty period, it will be replenished by the company. The company gives your body. And if it is outside your lifespan, you will take care. Then you are supposed to suffer for it. You got to pay. That is that it will help. So urea is basically coming from ammonia, which is coming from the breakdown of proteins in your body. Okay? Because the proteins will inevitably become what? A unit of proteins, amino acids. You remove the amine part by the help of oxidative deamination, glutamate dehydrogenase, to produce this urea by that. Isn't it person? Penile urethra. Where? Liver drive or sour liver. Do we like our liver? Do we like our liver? Why don't we like our liver? I want to excrete ammonia from my urine. I do not want to convert it into urine. I don't want to convert so much. What's the problem? Yes, the amount increases that will cause hyperacidity in your CSF. That will cause alkalosis in your brain. And that will cause your interparenchyma to shrink fast. This excess of ammonia will be converted into GABA. GABA aminobutyric acid, which is a negative neurotransmitter, and that will keep your accumulating in your brain. You start having fatigue fingers ending up in coma. That's why we don't like our body. We have to love. Okay? We love our body. So what we are able to do? We are going to put it in a urea cycle, which is actually a bicycle, to make urea and excrete it. Funny thing about urea is a very critical product. Sometimes here, sometimes there. The amount of the varies from 0 to infinity just like limits. Okay? You got dehydrated, you have increased urea. You did not take proteins at all last night, you have increased urea. So urea gives a snapshot of your body metabolism at that particular point of time. And it helps you to give point intervention for prevention of disease. Okay? It gives you a small opportunity to give point information in prevention and fighting. That is the application. Okay? Now, let us come to the parameters and what you will be actually needing to know. So, AFP or IFP. In AFP, you have urea, creatinine, and clearance. In IFP, you have sodium, potassium, chloride, uric acid. This is the entire spectrum of renal functions. you are supposed to know here is the what? Normal reference range. Polyuria is 8 to 15. Okay? Is it right? Absolutely right. It's 15 to 40. Some laboratories use 50 as well. Some laboratories use 50 as well. Then you have created is 0.5 to 1.5. 0.5 to 1.5. Then you have your sodium 135 to 50, 150. Then you have your potassium 3.5 to 5. Then you have your chloride 100 to 110. You have your uric acid. You have your uric acid, that is 8 to 21. pH 7.2 to 7.4. Bicarbonate 20 to 26. These are the normal reference range which my dear students you need to. But there is no other way in the world. How we will know for the next 40 years of your life that is there. And here address is characteristic to become the part of it. Okay? Okay. Got it? So with this, we have finished our small lecture of renal function test. Happy?
Because parliamentary knowledge is very important to understand the operative disease, to understand different types of operative diseases, to understand different types of respiratory problems. Last year in Australia and before, what is the difference between obstructive disease and respiratory disease? Obstructive disease and respiratory disease. Yes, inspiration, down, up, inspiration, down, right? So put it out. Eight down. Now, eight down. About Yakta. So Yakta will be good. Comes. And the pattern will be right? Agree? So তাই তো? এটা প্লাস কার্বন, এটা আবার তাহলে এটাকে যদি ডেবিট করতে হয়, এটাকে ডেবিট করতে হয় প্যাটার্ন ভ্যালু আর প্যাটার্ন ভ্যালু ফর এক্সপ্রেশন, এটাকে করতে হয় প্যাটার্ন ভ্যালু পি, that is pattern value with expression. So both are basically pattern value. This is pattern value. When we able to put the other thing into confusion to pattern value is called. অনেকেই বলে আপনি দাদা বিজনেস করেছে স্যার এক্সপেরিমেন্ট টোটাল বলতে হচ্ছে সেটাকে বলা হয় মানে এখানে আরো আছে কিভাবে ফাইবার not like that. এবারে I B I B হবে আমার এইখানে যে নরমাল কার্ভেশন হচ্ছে তার থেকে কম করবে রাইট and this is not down তাই তো তাহলে এই কোশ্চেনটা হচ্ছে আমার I B incidentally reason for you ভ্যালুটা বলবো and then this is here আর এইখানে যেটা বলি that is out তাই তো হচ্ছে বুঝতে পারছি এই যে হাফটা হচ্ছে এটা কি নাম হবে আয়রন কি বলবো আয়রন কি সিস্টেম বলবো সিস্টেম বলবো it is called spirogram it is called spirogram now so in exam theory it is written that just study the spirogram with all the problems and capacities then this is the right answer and then these are the volumes right now what are the capacities here is instrument কি হবে right hello আগে আছে ওখানে কায়দা হলো এই তারপর আমার কি হবে এটা রাইট এই কথা বলছি so this here is RC RC আগে আছে প্লিজ now so long volumes and long capacities may come to the exam. In exam, you have to divide fast into static and dynamic. Two things are there, that is a long volume and long capacities. I divided into static and dynamic. What does it mean? Static and dynamic? So when the dynamic is time, and it is not time at all. When it is time, that means it is flow rate. Flow rate means ml are made from oxygen. That is a flow rate. So we will talk about this environment or problem. This is the dynamic problem. Total respiratory system is able to test the diagnosis. Two to three things. Number one is the diagnosis of it. Treatment is producing from the body to facilitate comparison. Right? And then also some sorts of treatment is going on, and our indication is whether the position of the PLCO is preferable for the animal durance using or such as possible complete fibrosis. Before you detect in the spirometry, you can detect early in vital PLCO. Right? Normally PLCO is done in also case of pulmonary hospital problems in this. Embolism and condition problems, embolism. These are the detected by on the PLCO. That means what is the full form of PLCO? PLC of full form की last में पहले what is PLC? Full form of PLC तो कुछ चलेगा last में तो after that regular तो नहीं होगा yes what is PLC? Full form of PLC DLCO DLCO कहाँ है second note what is DLCO diffusion capacity of lung carbon monoxide दूसरे सामने बोले कम राष्ट्रीय से तो बहुत से DLCO is now term is called diffusion limited. After solution of diffusion limited, other solution of transfusion limited. That's it. DLCO is the drug. In these cases, it is important to understand how we should go through it. How we DLCO for the transformation. Usually, the spirometry is spiral non-active production, and another product is heat. So, we get two rulers. I go forward with it. So, these capacities at the bottom, you will find all equal values. They have the residual value and total value. So this is important and now ask that you know about some sorts of flow volume. The external components in the spirometry, non-capacities, non-volumes, DLCO, deep sea diving, deep sea physiology, hypoxia, active because periodic breathing, as well as asphyxia, hypoxia. It will not go and respiratory system usually to come to the world. We have to be the mechanics, cerebral, neural control, chemoreceptors, peripheral, and central. Wow, who are which is the main stimulus for the peripheral nervous system as well as which is the main stimulus for the central nervous system. Main center is the condenser, indirectly, directly is the and in case of filter, heat. CO2, Roma cell, বুঝতে হবে ওভার সেল হ্যাঁ এটি সেন্সিটিভ চ্যানেল অক্সিজেন সেন্সিটিভ এটি সেন্সিটিভ অক্সিজেন চ্যানেল এটা ইম্পর্টেন্ট সেটা তার মানে কি পড়াশোনা হচ্ছে খুব কম পড়ে পিছিয়ে যাচ্ছে হচ্ছে না সেম প্রবলেম তখন আগে তার বয়স এবার যে কথা বলতে সত্যি সত্যি নাই দুইটা প্রবলেম নিয়ে আসবে তখন তুমি না বলতে পারবে বুঝলাম তো সুপার প্রপার কেমন হবে what is the importance of that whether it is obstructing whether it is restrictive in case of obstructing it is a interpersonal or extrapersonal or inclusive or extensive whether it is these not may say in the spirometry already the practical concept of the approach is done in Isaac that is four things can be predicted. That's how force expression volume and heat are given. FeV1 are that. F and force vital capacity. So vital capacity and force vital capacity. Is it safe? No. Why? Force control time dependent and here as R1 plus species all of them developed AFV1 RC which is AFVC RC which is AFV1 by AFVC ratio AFV1 percentage there is percentage of this is F E V 25 75 percentage is 25 to 75%. After 25 to 75%. और आपके टाइगर को पुशी and then move then down एक down है एक्सट्रीमली पार्टी अपने चाहते हैं आपको तर एक bit of this 50% मालूम करके बोला है if we be one is a 1.7 25 to 75% in the second where is it? A means of this thing. अगर मुझे एक ऑब्जेक्ट है, ये volume है, mean expectedly flow rate वाला है. आज का नाम चलेगा mean expectedly flow rate. This is also called mean 50%. Not the whole हाँ, ये नॉर्मल होतो. जी होने एक वॉल्यूम जो है सबसे आपने वॉल्यूम में क्या वास्तव में वॉल्यूम एंड टाइम इज एक्सपेक्टेड टू कॉज आफ्टर द फ्लो वॉल्यूम कॉज आफ्टर दिस वॉल्यूम ऑफ टाइम का দুটো দুটো ভাবে ডাইরেক্ট ওয়েব রিপ্রেজেন্ট করেছে এই দুটো বুঝলেই স্পাইরাল ফিজিক্স হয়ে যাবে সিম্পল তাই এটা রাইট করে আর এটা ধরে এই জিনিসগুলো আমাকে বুঝতে হবে এফিভিএম মানে কি আমি ফোর্স এক্সপ্রেস করি আমি বিশ্বাস দিলাম এই ফোর্সফুলি চার্জটি এই ফার্স্ট সেকেন্ডের চার্জটি দ্যাট ইজ আওয়ার পি ফার্স্ট সেকেন্ড অফ what এফিভিএম টা আমরা রেসপেক্ট করা হয় এই রেসপেক্ট করা force vital velocity respecting secondly আমরা value expression করতে পারছি স্পাইরাল করছো যতটা খুশি দিয়ে ফুল বুঝলাম আর আমরা কম্পিউটার popular version of the is that is mostly so volume car. Another part of the that is volume time car. And volume time of volume. A volume time. Because volume and time. Volume is what? Time is second. Here we talk about resource level. After that, people put it away and then instead. That was one. Keep flow, keep expecting flow rate. After that, keep expecting flow rate. It means area of power. This is called follow time power. Let us see if one. Right second, next second, 2 second, 3 second, 10 second, 5, 6 second, 7, 8, 4. This one. And if you skip the date, where we have put a small example, then that will be the angle theta. Angle theta. So you can pick the pick this what? Pick steep is what? Pick expeditive flow rate. Up to which you can whatever you do, you can't increase the flow. That is the peak expeditive flow rate, and that is based upon this angle theta. Now, in your exam, suppose which is the maximum peak expeditive flow. A is the peak expeditive flow rate by A, B, or C, or A, B, or B, C. That's it. And A, B, C, and these are different. Most of these are A. So the peak expeditive rate for A is high, and C will. Right now, what will happen? The maximum point. Maximum point is first second the first second will be at the first second A is the volume. Second number F E B 1. A first second. Another number F B C. Shall we use A is the maximum point? A is one of these changes. This is a volume. This percent volume is called FVC. So the FVC1 is V1 means first volume capacity. That's why the ratio is important. Not the single value is important. Take it obstructive and non-obstructive. Individual value of the FEV1 is important only for the severity or bleeding of the disease. Suppose that the patient is FEV1 is a bronchitis level, but percent is a gentle and negligible is a moderate degree of obstruction and air obstruction, severe degree of and mild degree of. That is a percentage. Certain percent of the details about that. The concept is that whatever we just need the one second, volume takes we are getting the FEV1. Suppose one of the example are over percent. Here, the ratio the ratio is 4 by 5 100. What of 80% is normal. 80% is a normal. The ratio, if you give 1%, it is more this is from the ratio, not only that the percentage of 51, but percentage, and these percentage are important only for diagnosis of the obstructive and restrictive disease. If we give one obstruction zero, obstructive zero, this is if you want that, if you give it, respect. এইটা যত বেশি কমবে আপনাকে এটা কম কমবে তাহলে কি হবে এই রেশিওটা কমবে না বাড়বে ভালো কমবে এগুলো তো বেশি কমেছে কমবে ইজ লেস দ্যান 70% mostly theoretical is 80% normal if it is less than 70% that is the standard case of obstruction standard case of obstruction disease now last day example of obstructive disease. He party. You know. So, give 2-3 examples of obstructive disease. They will have to have this. Obstructive disease example here. How do you answer the question? Here we go. And we do the economic Here. This is going to as well. And the disease. One consists of then and was only legal problem then one is one obstructive problem is then one weaknesses system fibrosis. Okay, these 4 or 5 important examples of the obstructive disease. Restrictive disease is not good. Fibrosis. Primary fibrosis, vertical fibrosis, vertical fibrosis. So all these fibrosis are all fibrosis. Then disease, cirrhosis, okay. What you will do? Let's go. Let's go. You know what I'm Diffusion. Then you know that also. Mass is number this is for the muscular action. I want to ask you guys the number syndrome. So what is the basic basic problem? Last time I had this number. Now, number antibody against the voltage related reaction. I have to post synaptic reaction. It is acid against it. That is the one. You want to then otherwise restrictive and obstructive মাইন্ডে থাকবে একদম গোটা সিস্টেম, হ্যাঁ, একটা সিস্টেম কি আমাদের কোনো মডেল অরণ্য দ্যাট ইজ ফর অবস্ট্রাকশন এন্ড হ্যাঁ, আরেকটা সিস্টেম কি এই যে ওয়াশিং মেশিন সিঙ্গেল করে ঘুরবে না, কিন্তু এই দুই রকম ঘুরবে না, কিন্তু কি হবে রিপ্লেস হবে, কিন্তু এই প্রবলেম দ্যাট ইজ প্রবলেম অফ এন্টার অফ এয়ার আর এক্সেল অফ এয়ার প্রবলেম অফ সাবস্টেন্স that is called adversarial. So this is not the volume kind of, and here it is depicted as FV1 and FVC. বোঝা যাচ্ছে এইবারে আমরা একটা বিষয়ে অবস্ট্রাকটিভ প্রবলেম, তাহলে এই যে এই ডিএটা সমস্যা ডিএটা অবস্ট্রাকটিভ ডিএটা আমরা কোন একটা কি এক্সপেরিমেন্ট করে our theta angle is this, so we will do this. So in this way, we have to see what is FV1 and what is FVC. And FV1 is done in respect of FVC. Over respected with the photo passing. That is important for the passing of FV1. And FV1 percentage, if it is less than 70%, is obstructive fault. But in case of restricting first, here. Restrictive conduction. Restrictive conduction FV1 और FVC So in your spirometer, you see the normal level of FV1 and FVC ratio. Then you have to think restrictive pronoun. Don't do that obstructive pronoun. Always, if you want to obstructive, you have to less than 70%. That's a very different. Less than 70%. Number two, if the spirometry FV1 by FVC is increased, that is 100% is the what is it? But if FV1 and FVC is not, that the possibility of the restrictive is not the possibility. Let's say spirometry for the bioactive not complete. These are the obstructive restrictive. Both of them they will be another example. There will be like both of them watching parts. He action and only he can. After that, watching parts. So this is for the volume line parts. Also we flow volume part. That means this part of the second flow volume part. Is flow volume part spirometry other criteria. যখন কোন পার্ট আমার উপর দিকে যাবে, উপর দিকে যত পাওয়া যাচ্ছে এক্সক্লুসিভ নিচের দিকে যত আছে সত্য এক্সক্লুসিভ এরকম রামপুরা সরালে ঠিক আছে। এটা কাম করতে হচ্ছে সো অন দুটো হচ্ছে আর দুটো হতে পারে নাম হতে পারে দুটো হলে মানে আমার ক্লোজ হতে হবে, তবে এটা কনভার্টেড কি হবে। আমি বিশ্বাস করে আরম্ভ করলাম, কিন্তু আমি এটা আরম্ভ করলাম মানে this is not the negative or positive expression on the direction. This is the equivalent diagram that we decrease to the here. Total नाम है अरे ये नाम था total नाम व्यवस्थित नाम very shallow carbon on the technique experiment for a photo गया कार्य से दे बोलो क्या बोलो ना then you will flow it and decrease and like that now got the residual. You already know that cases ultimately, residual level cannot be detected by the biology. But theoretically, if you understand this is the respiratory phase and this is the expiratory phase, and these are the flow rates, and this is the point, this is the peak expiratory flow rate. Peak expiratory flow rate, and then down, and after this is the residual levels. There are two levels of it. Now, one important questions I like to mention when I go ahead to what is the clinical or forensic importance of the residual levels? Here, forensic importance of this is RP. Any idea? Or this is the thing. That's why I was very much strong at that point of the court after presenting very possible. And the years in the car. And then I was senior secretary of the graduates of the years in the car. And after that, and then so many of you that is stigma. What do you mean stigma? The stigma. Which has not associated we always do in case of any type of life science. In case of stigma, should not judge. I got attended a university level and that is a stigma. I simply rejected for the simply rejected. That is the main point. Simply rejected. So, doctors also asking that kind of that's why this subject is there as a great focus and legal problems, something there, something is common in life, but still, as a meditation, I have to look upon my quotations. If I want to say this, you can do that. But that is the problem for the forensic. And coming at that is the idea of the residual value. So I rejected a written statement of my staff that was just to make a decision. And I'm reading this. Right? Then call me, but the super I'm talking about you to this. Because the patient claims that he killed my child after the injury. So he killed my child anyhow after delivery. So his baby was a male child. This is very unfortunate. The male child was after 9 months of their marriage. But still, I have not myself. That's why you can't answer. So, I simply say, for the forensic and take the lungs of their child and once you can tell whether the residual problem is present or not. If the baby come out and break, that must be some problem is present. So, if the baby is kicked with lung issue, with the trauma of water, if it is here, present inside the lung, then it floats. It will float, and if it floats, that means our existing level, and I can be arrested. But that was undone. So there was no residual problem at all because the stigma is come out from the womb, then the baby was dead. The symptomism within 3 to 5 days, the both came finished. And then they realized that I appreciated what I have done there. Because still what I do, always from the danger, we have to inform that the baby was the legal one. As a patient, I think this is not an issue. You are working that's not my issue. Our parts are every life is that there is something that I will listen to this from my hand and I can to save the child. So, in our view, the emergency program is very important and we want in hospital also. And because of this, I is very well known my senior, so he is great job doing the therapies or diagnosis of sensitivity. Remember always that we can feel this like that. So always look at every knowledge that we see. So now on the original level, the outside of the suddenly we will find out the forensic expert to get I say very super. Just for the forensic department and postmortem is ready. Conduct one piece of time and then if it is working, I will decide whatever they will file and continue manually and do that. But if it is not, then it's a accept. So I don't know any you can know you want to go to see. So that is what the importance of the respiratory army physical volume in pharmaceuticals. So this is up to this physical volume and up to this PLC. It first this is a first particle. And a quick experiment for it is a quick. Now the question is that why is this quick? I mean, but I cannot hold the connection after this before. That is called dynamic fluid relation. That is called dynamic flow relations. We define that. It is simple. Dynamic flow relations means very simple. Suppose this is your branching and bicycle going on, so whenever you are explaining that means there is go have to move from alveoli to this one. Suppose this is your A point, this is the B point. So A to B to be a flow. If I get it good shape, expression of the expression is what? Very unclear. That means pressure intensity and frequency. At the end of the day, I am asked for the 761. I am approaching 60 years. 25. So we will have OB direction in. I have this here is pressure is drop by drop. And I have 61, I have 7, 60, I have 59 something one. I will go to the drop on the drop. Pressure drop on the sides. Number 1. Number 2. Pressure drop on the resistance. What kind of resistance? Frictional resistance. That is called air frictional resistance. That means frictional resistance to air. That is limited at R air resistance. That is also involved. This is happening in here. Now, it's also depending on the velocity. Depends on the velocity. What do you mean by velocity? Velocity is basically flow and area. And area means cross-sectional area. If cross-sectional area is more, then velocity will be less or more? Yes. If it is less, it is more. More, it is less. Cross-section area is A should be the cross-section area is center and more area the cross-section. The cross-section area will be area which you want. The velocity area here. And then right? Here will be velocity to receiver. Now pressure will come. That is called trans-level pressure. It is going to be original. Air pressure minus flow pressure. And actually, air pressure minus flow pressure. This trans air pressure. It will keep on saying landscape. Expand medical college. This pressure. Let's say, even if we take this figure to expression of our knowledge of cheddar, After the peak, এখানে যে রিচ করেছে পিক হবে অনেকটা আছে আছে that means pressure এখানে ultimately is flow rate flow কি আছে দেখো flow rate আমার কমবে যদি আমার কি হয় velocity কমে তাহলে velocity এর বেশি আছে কি জানেন pressure drop is more pressure dropping is more and this pressure inside the air will be less so if it is less dropping is much more rate তাহলে কি হবে এখানে বাইরে থেকে pressure থেকে উঠে that causing the narrowing of this form if this narrowing happening as well as the arc is the same ultimately flow rate will be less whatever the volume of the कुछ नहीं लगेगा और ट्राई करो फ्लो रेट में फ्लो रेट will increase ultimately to come the acidity area of the vesicle volume and then again the expansion এটা ভুলবি না এই রাস্তা দিয়ে বলতে হবে যদি কেউ কেউ যে রেগুলার এক্সপ্রেশন করার চেষ্টা পাওয়া না আর তাহলে এটা পজিটিভ এটা নেগেটিভ না Yes, sir. They are the introduction. Higher confidence. Let's check. Now in this abstractive clause. Abstractive clause is our abstractive clause is our argument. Here, abstractive meaning. They put the structure. The argument. Huh? Here. रामों के जब पानी आगे वाला एफर्सी माने की अगला हाँ इंसिडेंट बहुत अच्छी एक्सपीरियंस बहुत अच्छी दैट वाज एफर्सी राइट टोटल नाम के पास अगला restricted short form. Restricted short form. Now, whenever it is dealing with the flow molecule, if the move is transported in the left, then it is the obstruction. Restricted is transported in the right. Right side means what? Easy. राम कभी पाप का इंग्लिश हो जाएगा This is for the right circuit of this soul mostly restrictive arm for right. Now it is going like that way, air way. Here, that's it. We can operate air way, aeromotion. What is this term is called? Moving. Very good. This is called moving also. So moving. And also, it is shifted to the left of the restrictive right. Is a restrictive right. So these terms we have to again and again to do the correct and also if you deal with restrictive cases for your exam paper, you have to shift this now to the right side. And all the bubbles and capsules almost you will make degrees so that if you give one and if we see the ratio either increase or not. But in case of obstructive, that means flow will shift it to the left, and if you want and if you see to be less than 70%, that is it. If you want to get the percentage individually of these things if you want, then we have to carry forward the percentage of every one ABC is 0 to restrictive dignity. Suppose one goes obstructive. How can we use 0? That is obstruction to emphasize 0 or obstruction to non-harassment. Even silent is obstructive. How can we detect that or not? Non-harassment. How can we detect that? In that case, one of the important things is that, computer the computer is the opinion that so post computer article DLC. Article DLC. The DLC is normal. A mere normal is also normal as object. It will increase. It's definitely 100% Reaction gives you action or option. So first of all, in this phenomenon, which one you want to foresee the issue? If it is less, then we have to see the P, efficiency. If it is efficiency, we have to figure out what kind of construction and so do the PLC. That is diffusion limited heat. Diffusion limited carbon dioxide capacity. These things are happening, and so this group is very important to understand and get with the restrictive aspect. So restrictive inside, obstructive inside. Every component used to differentiate between these and these. Obstructive due to the suitability and obstructive due to the non-cancer, for the disease. And this big restrictive for the air is already a quantity. Now, at the present moment, we begin to talk at the present time, after I have a human awareness. So, the air is competition. Kada key. Kada man kada mo. Kada mo. So, kada key na mo. Our something of such. একদম ছুটে তাহলে আবার সাক্ষী তখন বিক্রি করে এই যে সব অবস্ট্রাকশন ডিজিজ প্লিজ এক্সপেরিয়েন্স ফর লিটল ডাউন মোর ডাউন দ্যাট আ পেন এখান থেকে যে আকর্ষণ আছে যে আমার অবস্ট্রাকশনের জন্য obstruction is a big problem. Disease will be down of normal. Normal that flow, but 8 also on normal. 8 also on normal. So everything is low. Restrictive on but not much than the obstructive control. But it is your expected for the less obstructive and restrictive flow. In case of obstructive, the expected flow will be much more or less lower than the restrictive. Now, if it is in first is obstruction is there, so there is no such thing. Then a flat variable. So like how you can diagnose. Whereas I will normally take the obstructive and restrictive. It details the many diseases along with the lung. Whereas so fibrosis, tumor, cancer, everything these things happens, it will be hampered by this program. Any questions of this? So this is absolutely science and physics responsibility is there. This is not important for the exam, Santiniketan also. And so if you are not in this exam, it is also important for the professional education also. So be very careful. I have already finished my chapter. Now the AOD and the junior class And if you have any interest in any special topics of anything, say, you can say, ask, then we to take the success. Even if now, specifically, because they are going to ready to the area. And series is going on, there is a serious chapter, very long. So if any subject that is important for the exam, you have to study. So please, you can really introduce the knowledge of to make a fixed routine and take it in our participation. Okay? Thank you very much.
কিরকম থাকে অবলিকটা তো কিভাবে থাকে এইভাবে থাকে তো অবলিকটা কিভাবে থাকে how does it will form it will take origin from the sternum and the clavicle and where it is going mastoid process আমরা অবলিকটা কিরকম করে থাকে so অবলিকটা থাকবে suppose this is the mastoid process this is the clavicle so one end would be like this okay so this is which border this is posterior border of sternocleidomastoid okay and this side you are having the anterior border of trapezius okay so which thing will form the base korbe ki medial two-third of clavicle right now this one is the by the medial tooth so this one is the sternocleidomastoid which border again it is the posterior border okay again it is the posterior border and trapezius which border the anterior border of trapezius could you tell trapezius original insertion and what is this clavicle which thing medial two-third trapezius এর original insertion কোথায় হতো trapezius এর original insertion কোথায় হতো so if you see the nuclear line মনে আছে superior nuclear line কি কি তিনটে মাসেলে অরিজিন হয় কি কি একটা হচ্ছে তারপরটা হচ্ছে sternocleidomastoid তারপরটা হচ্ছে splenius capitis the trapezius এর অরিজিন কোথায় হলো medial part of the superior nuclear line ঠিক আছে এবার ইনসারশনটা কোথায় হবে বল spinous process উপরে আর clavicle very good so it is on the scapula it is on the scapula both side and it is forming one rhomboid shape on the posterior surface of neck বুঝালো superior nuclear line থেকে এইভাবে একটা rhomboid form হচ্ছে okay so this is the boundaries of the posterior triangle okay so just write it down now which structure is making the roof okay so roof for anterior triangle and posterior triangle are different okay anterior triangle এর রূপটা বল কি কি বলেছিলাম আমি skin then superficial fossa what are the content superficial fossa কি কি content পেয়েছিলি platysma আর there is one jugular vein which jugular vein anterior jugular vein and both side right and left দুটো আছে দুদিকে okay আর there is lymph nodes submental lymph nodes and the submental branches of facial artery okay this is the superficial fossa content on the anterior triangle what about the posterior triangle again write it down posterior triangle the roof is formed by so if you are talking about the roof so how does the roof will form so number 1 is skin okay there comes superficial fossa now the question is what are the content of superficial fossa ki ki content hobe bol superficial fossa এখানে যদি থাকে তো jugular vein anterior jugular vein বলে ওখানে কি থাকবে posterior jugular vein okay and it is also a content of both are coming from where anterior and posterior both are coming from external jugular vein so external jugular vein itself is a content of posterior triangle total okay the first content write it down first content pabi again platysma will come okay platysma will come then second one is external jugular vein and posterior jugular vein okay are additionally there are four nerves okay which are they write it down first one is অনেকগুলো content আছে okay posterior triangle having lots of content so if you talk about superficial fossa first thing you will get the platysma Okay. Second one, you will get the external jugular vein. Okay. So one thing about the external jugular vein, write it down. Two clinical anatomy associated with it. With the external jugular vein. Number one is where to locate. Do you know where to locate? Surface anatomy of external jugular vein kothay hote pare? So you will get the structure over here. Okay, at the corner. Okay, at the side of the clavicle and where the sternocleidomastoid start. Okay, there you will get the external jugular vein. So write it down. External jugular vein is piercing the deep cervical fossa. It is piercing the deep cervical fossa. Okay. So if it is piercing the deep cervical fossa, so suppose the cut has been made. Okay, by anyhow the injury has been made to this area. What will happen? Injury or the cut to this section of the neck. What will happen? So as because, write it down, as because external jugular vein or AJV is the content of the deep cervical fossa itself. Deep cervical fossa itself. Sudden cut or injury to this surface will also leads part of the external jugular vein, isn't it? So what will happen? Suppose other vein is there is any cut, what will happen? Cut hole ki hobe? Vein cut hole ki hobe? প্রথমে kind of bleeding হবে, right? Passive bleeding হবে, afterwards কি হবে? Vein collapse করে যাবে. But it is not occurring in case of external jugular vein. Okay, why? Two reasons. One is it is the content of this deep cervical fossa. Okay, ওই fossa-রি content, সুতরাং fossa-টা direct থাকবে, vein-টাও direct থাকবে. This is one reason, and it does not got any valves. Okay, so write it down. So if any cut injury to the deep cervical fossa, it will also cause part of the external jugular vein, but it does not collapse. Okay, as it relaxes during relaxation of the deep cervical fossa, due to relaxation of the deep cervical fossa, and another one, it does not contain any valves. তো এবার ধর যদি কোনো ভাবে কাটটা থেকে গেল vein and vein surface is open, what will happen? The air will go to that area. যদি air ঢোকে কি হবে? There will be air embolism, pulmonary embolism, and it will cause sudden death. So that's why it is very much clinically important. So এটা number 1 point of the external jugular vein. আরেকটা কি important point? Second one, from here we used to measure the venous pressure, central venous pressure, যেটা আমরা CVP লাইন করি না, সেটা কোথায় করি? এই external jugular vein করা। So write it down. To measure the ICCU তে যদি গিয়ে থাকি স্যার দেখতে পাবো। ওকে, jugular venous line কি করে করে external jugular vein। ওকে, so why we are taking the pressure? কেন এখানে central venous line করা হয়? Because it will give you the accurate reading. হার্টে কি চলছে সেটা কিন্তু external jugular vein বলে দেবে। How? Because it is having same pressure as the right atrium. Okay, so write it down. Second one, the external jugular vein is used to measure the central venous pressure. During ICCU and emergency procedure. Because it coincides with the pressure of the right atrium of heart. it coincides with the pressure of the right atrium of heart. So these are the two clinical anatomy related to the external jugular vein. And how does it will form? External jugular vein কি করে তৈরি হয়? Do you know? It will form on W. I said how? Write it down. External jugular, এটা কিন্তু MCQ আছে. External jugular vein is formed by posterior auricular vein. Posterior auricular vein you are aware of? কোথায় থাকে? Just behind the ear. So first one is the posterior auricular vein. আরেকটা কোন vein? Posterior division of retromandibular vein. Okay, posterior division of retromandibular vein. So these two will form the external jugular vein. Okay, but external jugular vein এর কি কি tributary পেরি? একটা পেরি anterior jugular vein in the anterior triangle, another one is the posterior jugular vein. আর anterior jugular vein কটা আছে? Both side two. Okay, which will again join with কার সাথে জয়েন করে? এর আগের দিন বলেছিলাম it will form one arch. Okay, left and right this anterior jugular vein it will join the external jugular vein. তাই না? venous drainage এখান থেকে নিয়ে গিয়ে external jugular vein এ বের হবে. Okay, now next one is the nerve. Write it down, which are the nerve. So first one you got the vein, external jugular vein and posterior jugular vein. Now coming to the nerve. How many nerve are there? As many as 4 nerve. Which are they? Kiki number? Do you know which are the superficial nerve? Superficial nerve. এটা ডিপ সার্ভাইকাল ফাসাতে পড়েছে। ওকে, ডিপ সার্ভাইকাল ফাসায় অনেকগুলো কি করে প্রিভার্টিব্রাল ফাসা থেকে ইনভেস্টিং লেয়ার অফ ডিপ ফাসাটাকে ক্রস করে সামনে আসে। ওকে, so write it down. First one is the lesser occipital nerve. First one is the lesser occipital nerve. কোথায় পেয়েছি এটাকে? Lesser occipital nerve. Where you got? Lesser occipital nerve you got on the scalp. Scalp पे पेয়েছিলি না? Lesser occipital, greater occipital, third occipital. তাই না? So first one is the lesser occipital nerve. Root value কত হবে? C2. Root value হবে C2. First one is the lesser occipital nerve. Okay, root value কত? C2. Then second one is the great auricular. Great auricular কোন এরিয়াতে সেন্সরি সাপ্লাই দেয়? জেসে throughout face sensory supply কি বলেছি? From the trigeminal nerve, তাই তো ophthalmic division, maxillary division, mandibular division. তাহলে কোন এরিয়াটাকে দেবে না সেটা দেবে, that will be provided by this great auricular nerve, that is nothing but the angle of mandible. Write it down. Angle of mandible of the face, sensory supply of angle of mandible is supplied by great auricular nerve. Root value কত? C2, C3. Okay, then the third one is transverse cervical nerve. Transverse cervical again is C2, C3. বুঝা গেল? Transverse cervical nerve. Last এটার কি নাম বল? Last এটার নাম হচ্ছে supraclavicular nerve. Okay, supraclavicular nerve. এর ভ্যালু কত? C2, C3, C4. ঠিক আছে? So these are the 4 nerve you will get on the posterior triangle. So this is only I am talking about the superficial fossa. Okay, so next which thing you will get? Once you take out the superficial fossa, you will get the deep fossa. Okay, so deep fossa কোন layer গুলো পাবি? Write it down. Deep fossa are investing layer of deep cervical fossa. এই চারটি না ভীষণ ইম্পর্টেন্ট। Okay, so deep cervical fossa হচ্ছে investing layer of the deep cervical fossa. Okay, Then coming to the floor, very much important, floor টাকে তৈরি করছে. So see, if you see the floor of the posterior triangle, you will get all the muscle, layer of muscle is covered by a very thin layer of fascia. Okay, that is nothing but prevertebral layer of deep fascia. Okay, so write it down. All the muscle which are present, all the muscle which are present on the floor of the posterior triangle, which are present, the floor of the posterior triangle are covered by কোন লেয়ারের সাথে কভার থাকে? ভীষণ ইম্পর্টেন্ট, prevertebral layer of deep cervical fascia. Okay, so suppose how you will take the dissection line for this posterior triangle. Posterior triangle টা কি করে লাইনটাকে dissect করবি? First thing you have to say, we are talking about the posterior border of sternocleidomastoid, right? But we won't cut on the posterior border. ঠিক আছে, কোন বর্ডারে কাটবো? anterior border. কেন posterior border কাটবো না? So এটাও explain by আসতে পারে, write it down. The dissection line for posterior triangle is always made on anterior border of sternocleidomastoid. Anterior border of sternocleidomastoid instead of posterior border. So কি আমাকে রিজনটা বলবে? রিজন কি? Explain me this why. যদি ধর posterior border থেকে কাট করি কি সমস্যা হতে পারে? Because you are seeing all the superficial nerve, it will get cut. Okay, so write it down. All the superficial nerve which is originating from the posterior border of sternocleidomastoid. You have to name this four nerve. Okay, originating from the posterior border of sternocleidomastoid get damaged. Okay, so that's why we are giving the anterior line. তাহলে প্রথমে ইনসিশনটা কোথায় দিবি? On the anterior line. Okay, so we will give one incision to the anterior line. Okay, এখানে একটা ইনসিশন হয়ে গেল, আরেকটা ইনসিশন কোথায় দিবি? From the sternocleidomastoid to the, এটা ক্ল্যাভিকলের কোণে, lateral limb of clavicle, তাহলে এখানে একটা আরেকটা ইনসিশন দিবি। ওকে, আরেকটা ইনসিশন কিন্তু যেটা দেয়া হয় সেটা হচ্ছে you should not cut this area. ঠিক আছে, নেকের সাইডটা কাটা যাবে না, ট্রাপিজিয়াম সাইডটা কাটা যাবে না, কোনখানটায় কাটবি? বুঝা গেল? Just to reflect the skin away. Okay, so these are the three incisions. Okay, so now we are talking about the floor. So once you have taken the skin, once you have taken the platysma, you will come across the superficial nerve, then coming to the prevertebral layer of the deep cervical fascia. So you have to just take it out. It is a very thin layer. Once you cut, there are as many as 4 muscles. Okay, one by one. So first one is, write it down. প্রথমে কাকে পাবি? এই এরিয়াটাতে কাকে পাবি? First এরিয়াটাতে পাবি splenius capitis. Okay, this one is for the splenius capitis. Next one is for levator scapulae. Okay, and then next one you will get purotype পাবি the scalenus medius. বুঝা গেছে? And additionally you will get over here আরেকটা মাসল পাবি যেটাকে বলছে supraspinous capitis. Okay, so this is another one, semispinalis capitis. Last one is the semispinalis capitis. Okay, so write it down. Floor is occupied by splenius capitis. কোথায় পেয়েছি সেটা আগে? splenius capitis কোথায় পেলাম আমরা? superior nuclear line. superior nuclear line এর সবথেকে lateral line, মানে ফার্স্ট কন্টেন্ট কি? splenius capitis. Second one is levator scapula. Levator scapula किसका muscle? हाँ? So where is the origin? Levator scapula बोला है, origin होता है होगा। যেদিকে তো গ্লিনোয়েড ক্যাভিটি আছে সেদিকে না উল্টো দিকে যেখানে স্পাইনটা শুরু হচ্ছে কর্নার সেখানে হচ্ছে লিভেটাস স্ক্যাপুলা কি মেইন ফাংশন টু এলিভেট দ্য স্ক্যাপুলা সো ইউ উইল গেট দ্য লিভেটাস স্ক্যাপুলা থার্ড ওয়ান ইজ তিন নম্বর কাকে পাবি স্কেলিনাস মিডিয়াস স্কেলিনাস মিডিয়াস ইজ দ্য মাসল অফ ওদাইটিস that which is called scalenus medius তিনটে পাওয়া গেছে so that is nothing but content of the rib তাই না first rib which is scalenus medius scalenus anterior scalenus posterior ঠিক আছে scalenus medius টা তাহলে পাবি আর এটা হচ্ছে semi spinally scapula এটাকে কেন মেজর কন্টেন্ট বলছি না বিকজ each and every individual has got different structure of the posterior triangle okay but you will definitely get these three muscles এই তিনটে মাসেল পাবি অ্যাডিশনালি সুপিরিয়রলি কাকে পাবি সেমি স্পাইনালি স্ক্যাপুলাস ঠিক আছে ইনফিরিয়রলি সেইভাবে আরো তিনটে মাসেল পাওয়া যায় which are they কি কি পাবি স্কেলিনাস মিডিয়াস along with scalenus posterior scalenus anterior and first digit of serratus anterior ওকে এই তিনটে একটু লিখে নে অ্যাডিশনালি পোস্ট এই এরিয়াতে দেখ এই এরিয়াটা যেখানে শেষ হয়ে গেল so that is the scalenus medius so you will also get the scalenus posterior then next one is scalenus anterior আর serratus anterior কতগুলো ডিজিট আছে how many digit serratus anterior and supplied by which nerve serratus anterior কটা ডিজিটেশন আছে ডিজিটেশন না it will take so many digital origin তাই তো 8 digitation ঠিক আছে as many as 8 digitation so among them huh 8 digitation okay so we are having only first digitation of serratus anterior কোথাকার muscle it is also known as key muscle bola hoy etake boxer muscle and it is supplied by which nerve so that is also known as nerve of Bell it is also long thoracic ঠিক আছে এতগুলো ডিজিট কে সাপ্লাই করতে হবে এটা লং thoracic nerve of Bell okay so this is about the nerve the floor of the posterior triangle okay now we are coming the subdivision anterior triangle এর সাবডিভিশন কোন মাসল করেছিল কটা সাবডিভিশন আছে চারটে সাবডিভিশন আছে 3 and half is the submental triangle আর তিনটে সাবডিভিশন কি কি হলো একটা হলো তো ডাইগ্যাস্ট্রিক আর সাবম্যান্ডিবুলার ট্রায়াঙ্গেল আরেকটা হচ্ছে ক্যারোটিড ট্রায়াঙ্গেল আরেকটা হচ্ছে মাস্কুলার ট্রায়াঙ্গেল so that have been done by which muscle superior belly of omohyoid এখানে কি সেপারেট করবে inferior belly of omohyoid the inferior belly of omohyoid is inserted where কোন বোন থেকে নিচে অরিজিন তো সুপিরিয়র বেলি ইনফিরিয়র বেলিটা কোথায় যাচ্ছে again it is scapula okay again it is scapula ঠিক আছে so inferior belly of omohyoid so how the subdivision has been made so write it down posterior triangle is divided into two subdivision okay so this is suppose the posterior triangle okay so where the superior the inferior belly of omohyoid কোন জায়গায় থাকবে সো এখানে যেখানে লিমিটার স্ক্যাপুলি আছে এর থেকে একটু নিচে ওকে এইরকম একটা জায়গা করে ক্রস করবে ওকে সো দ্যাট the whole posterior triangle is divided into larger এটাকে কি বলছে occipital triangle and smaller supraclavicular it is also known as আরেকটা এটা কি না homoclavicular ঠিক আছে নিচের পার্টটাকে বলছে homoclavicular so subdivision has been done by inferior belly of humohyoid কি কি ডিভিশন দিল একটা হচ্ছে লার্জার occipital triangle okay and another one is smaller supraclavicular or also another name ki homoclavicular okay so it has been divided into two subdivision okay now one by one triangle we will discuss so there is one difference you will get in your textbook okay between the difference between the occipital triangle and the supraclavicular triangle which thing you have to know what are the content okay difference between the content okay so write it down first one is for the occipital triangle so এবার বল occipital triangle এ কি কি content হতে পারে occipital triangle এ কি কি content হতে পারে এই সব কটা নার্ভ যতগুলো নার্ভ পড়েছিস চারটে নার্ভ সব কটা কি কি বললাম একটা হচ্ছে লেসার occipital great auricular then transverse cervical then last one is the last nerve will come no only three nerve okay write it down three nerve lesser occipital great auricular and also the transverse cervical nerve okay additionally you will get additionally you will get the occipital lymph nodes okay now coming to the supraclavicular triangle so what will be the content so you know the supraclavicular nerve has got three divisions okay so they are C2 C3 C4 বুঝতে পারলি supraclavicular nerve এর কত ডিভিশন তিনটে all are directed downwards to the supraclavicular triangle okay so additionally আর কি কি পাবি ভীষণ ইম্পর্টেন্ট স্ট্রাকচার that is root and trunk of brachial plexus okay root and trunk of brachial plexus now tell me root মানে কি কি কোন কোন নার্ভ আসবে root and trunk of brachial plexus কোন কোন নার্ভ আসবে all will come but you have to specify the name nerve to প্রথম নার্ভটা কি nerve to serratus anterior number 1 nerve to serratus anterior or it is also known as long thoracic nerve or the nerve of death okay আচ্ছা ওখানে আর কি মাসল আছে you are talking about just below the clavicle so which muscle is there subclavius right so subclavius so nerve to subclavius and another one is below the scapula that is nerve to subscapularis subscapularis concept কোথায় থাকে nerve to sub subscapularis বলে কোনো মাসল আছে scapular medial okay then next one is the স্ক্যাপুলার দুটো বড় ইয়ে সারফেস আছে না, একটা তো অ্যান্টেরিয়র সারফেস, একটা পোস্টেরিয়র সারফেস। অ্যান্টেরিয়র সারফেসে কে নেবে? Subscapularis, so that is known to subscapularis. Now coming to the posterior side of scapula, which are the muscle you will get? Main muscle. So there is a spinous process running, has got two muscles, supraspinatus, infraspinatus. So next one is suprascapular nerve. দুটোকেই কিন্তু সাপ্লাই করবে কি? Suprascapular nerve. Okay, দুটোকেই সাপ্লাই করবে suprascapular nerve. So root and trunk of brachial plexus. These four nerve you will get. Okay. And additionally, which lymph nodes? Supraclavicular group of lymph nodes. And why the clinical anatomy of supraclavicular lymph nodes are important? When does it get swelled? Supraclavicular lymph nodes. বার করেছিস। The varicose lymph nodes. Gastric carcinoma. Okay, gastric carcinoma, you will have elevated supraclavicular lymph nodes. This is also known as varicose lymph. Okay. VIRCH varicose lymph. Okay, so these are the two clinical anatomy related to this two triangle. Okay. And additionally, what are the things you have to study in the posterior triangle? That the lymph nodes. Okay, একটা হচ্ছে তোর ওখানে occipital lymph nodes পাবি, এখানে পাবি তুই supraclavicular lymph nodes. আচ্ছা, omohyoid chiefly you will get on the supraclavicular triangle. Okay, so that's why you are saying omoclavicular triangle. Okay, so now we will go and see in the dissection. Okay, dissection of posterior